All right, so I'm Louise. We're going to be going over the head-to-toe assessment today. Generally, the head-to-toe assessment, it's used by nurses to discover any problems. So sometimes in the hospital setting, we already know what the patient is admitted with. For example, our patient might have come in with abdominal issues. However, during their stay here, she might develop a blood clot in the leg that could lead to issues in the leg, or she might develop a stroke or a heart attack. So we always do a head-to-toe assessment at the start of every shift just to make sure that there's nothing else unexpected going on. So the head-to-toe assessment is basically what it sounds like. It's going from the top all the way down to the toes and looking and skimming the body for any problems. Once we discover a problem, that's where we go more in depth and do a focused assessment. You will learn about focused assessments later on in the course. Right now the idea is just to do head to toe and skim the body for problems. So before you do a head to toe assessment, you always do a complete set of vitals: pulse, respirate, SpO2, temperature, pain, and blood pressure. If anything's abnormal with that, you need to address it. Then we're going to do our head to toe assessment. In this case, everything's going to be fine.
Let's hope so.
All right, so to begin with, I'm going to introduce myself to the patient, do some hand hygiene, and provide privacy. So, hand hygiene. Hi, my name's Louise. What's your name?
Elise.
Elise. All right, I'm going to be your nurse today. I'm just going to do a head-to-toe assessment just to make sure everything's okay.
Okay.
All right. Provide privacy. So we're going to start with the neurological assessment. We always start with neurological, then we move on to cardiac, respiratory, gastrointestinal, genitourinary, integumentary, which is skin, okay, musculoskeletal, and then at the toes, we do neurovascular as well as the fingers, okay? So I'm gonna start with neurological. So I've already asked her who she is. She does know who she is. Can you tell me where you are right now?
Phalanx.
Wonderful. And what month is it?
March
And what year?
2019.
Perfect. All right, so the next thing that I'm going to do is I'm going to check her pupils, okay? Now, I don't have a pen light on me right now, but I'm just gonna look, are they equal, okay? Open your eyes nice and wide for me. They are shrinking and reactive to light. If I had a pen light, I would shine the light in her eyes, okay? Moving on, I'm going to check her grip and leg strength. This is still related to neurological because it's going to show me whether she's having a stroke or not. So I'm going to cross my fingers and ask the patient to squeeze both my fingers as tight as you can, tight, tight, tight. Well done. So what I'm looking for is, are her grips strong and are they equal strength? Moving down to the, I'm going to ask Elise, push down like you're driving a car. Push, push, push. Well done. Nice and strong and equal. And pull up. There you go. Well done. She's aware of who she is, where she is, what's going on. Her pupils are equal and reactive to light. She has strong and equal grip strength as well as feet strength bilaterally. I'm quite happy with how her brain's going. While I'm here at the head, I'm also going to take a quick look. I'm looking at her hair. Is it washed? Is she well kept? Do I see any lice or nits? Do I see anything abnormal with her skin? Are her eyes sunken into her head? Are her lips looking blue or cyanotic or dried out? In this case, everything's looking okay, so I'm moving on. Next step is the cardiac system, okay? So what I'm going to do is I'm going to look at her as a whole. If she's having cardiac problems, oftentimes the patient is going to appear generally unwell. She's going to either look pale or flushed or gray, or she's going to look diaphoretic. Looking at Elise right now, I don't see any of that stuff. If the heart's not pumping well enough, that means that it's not pumping enough oxygen to the body. Her lips might also look cyanotic or blue. I do not see that, okay? Glancing at her legs, sometimes if the heart's not pumping well enough, you can get what's called edema or swelling in both legs. I'm not seeing that just from over here, but I'll take a closer look a little later on. So now I'm going to listen to her heart. What I'm listening for is just the general S1, S2 sounds, which is the lub-dub, dun-dun, dun-dun, okay? If I hear, what I don't want to hear is anything other than that, okay? So some patients you might hear dun dun, dun dun, dun 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 dun, dun dun, dun, dun dun, okay? That's abnormal. All I want to hear is a regular rhythm, lub-dub or dun dun, okay? Sometimes you might hear a whooshing sound like a shh, shh. That's called a bruit. That's not normal either. All I want to hear are the 2 beats, okay? So, I'm gonna take my stethoscope. The heart is situated a little bit more on the left side, and I'm just placing my stethoscope so that I can hear her heartbeat. I do hear the heartbeat. It sounds regular. It sounds loud. Sometimes you might hear the lungs as well. At this particular moment, I'm just focusing on the heartbeat. I'm quite happy with how that's sounding. All right, so moving on, next is the respiratory system. Again, I'm gonna start by looking at her. Do her lips look cyanotic and blue because she's having difficulties breathing? No, they look fine. I'm gonna think back to the vitals that I took. Her respirate and her SpO2 levels were within normal limits. I'm also going to look at how she's behaving. Right now she's lying supine or semi-reclined, and she doesn't appear in respiratory distress. A patient in respiratory distress will be sitting up, going using accessory muscles to breathe. So already I'm assessing her respiratory system just by looking at her and considering the vitals that I took. So the next thing that I'm going to do is I'm going to auscultate the respiratory system. So do you mind sitting up and swinging your legs over the side of the bed? So she has 5 lobes in her lungs, 3 on one side, 2 on the other, but we generally listen in 6 spots, okay? You always listen on the opposite side. So 1 spot, 2 spot, 3 spot, 4 spot, 5 spot, 6 spot. Make sure you go low enough. The ribs actually go quite low on a person, and the lungs go as far as the ribs. I find students tend to stop listening right around here, whereas we've got the lungs that go lower. What you're listening for is the inhalation and the exhalation of the patient, and you should hear the whooshing of the air going in and the whooshing of the air going out. What you don't want to hear is adventitious sounds, which is crackling or wheezes. Crackling indicates that there's fluid in the lungs or an infection brewing. Wheezing occurs when the airways are narrowed. Generally, you see that in people who are having allergic reactions or who have asthma, okay? So, do you mind swinging your legs back up on the bed? When you're auscultating, just stay sitting up, you never listen on top of the clothes. You always go under. So I'm going to just slip my stethoscope under her shirt, and it will be cold. And just take nice deep breaths. Usually having the mouth open helps with those deep breaths. So I'm hearing the inhalation and exhalation. And I'm just checking out those 6 spots that I mentioned before. Try to listen between the ribs in the intercostal spaces. It's quite difficult to hear if you're listening on top of bone. If you can't hear quite well, then shift the stethoscope a little bit. All right, thank you. You can lean back. So that's sounding quite normal, and I'm quite happy with that. Now, at the same time as we're doing the head to toe assessment, we can be asking our patient questions such as, do you feel short of breath?
No.
Do you find that you feel puffed with the slightest bit of activity?
No.
No, you're quite comfortable with going up a flight of steps or walking to and from the cafeteria?
Yep.
Okay, wonderful. All right, moving on to the GI system, the abdomen, okay? So I'm gonna have you pull up your shirt.
I'm gonna do that one.
Thank you. Okay. So there are 4 things that we do here: inspection, auscultation, palpation, and percussion, okay? For any body system, we always inspect, and then depending on the system, we might do the other 3. So the first thing I do is I'm inspecting her abdomen, okay? I'm looking, is it rounded and distended, or is it flat, or is it concave? What I'm seeing here right now is a flat stomach. I'm also looking for anything abnormal on her skin, okay? No abnormalities noted. Do you have any pain in your stomach or any nausea?
No.
I always like to ask that before I start poking and prodding. So the next thing that I'm going to do is I'm going to auscultate. So if we look at her stomach, we imagine that the belly button is in the center, and we're going to divide her belly into 4 quadrants. Right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. I'm going to listen to each quadrant. What I'm listening for is gurgling. I want to hear some gurgling. I should hear sounds within 10 seconds. As soon as I hear sounds, I move on. If I don't hear sounds within 10 seconds, I'm just going to shift my stethoscope a little bit. Okay? If I still don't hear sounds, could be that something's going on and you should speak with the charge nurse. So I hear sounds in all 4 quadrants. So we have done inspection and auscultation. The next thing we're going to do is palpation. So I'm going to take my 3 or 4 fingers here and I'm going to feel. Now there's shallow palpation and deep palpation. Most people, we do the shallow palpation, which means you push about 2 centimeters in. If you have an obese person, you might need to go a little bit deeper, as far as as deep as up to 5 centimeters. When I'm palpating, I'm feeling for any masses, any lumps and bumps that I wouldn't expect to find there. At the same time that I'm palpating, I'm watching my patient to see if she's flinching or uncomfortable, okay? It shouldn't be a comfortable sensation of me palpating, but it certainly shouldn't hurt her. If it hurts her, that's an area of concern. When I palpate, I generally palpate in at least 2 areas within each quadrant, just to make sure I'm covering most of the quadrant. So I'm not feeling any lumps or bumps that shouldn't be there. And does that hurt or is it uncomfortable? No. Wonderful. So the next thing that I'm going to do is percussion. This is the last. So we've got inspection, auscultation, palpation, and percussion. Percussion is where you're essentially tapping your fingers on the belly. What you should hear, and it's almost hearing as well as sensation, is a hollow sound, okay? If I was to move up and do it on her ribs, I would hear a different sound. That is a sound of something solid. You shouldn't be hearing something solid in the belly. If you do, it could indicate that there's a mass that should not be there, or that she's constipated, or possibly has a bowel obstruction. Thank you. So while I'm at the abdomen, I'll take an opportunity to ask my patient some questions. When was the last time your bowels opened?
This morning.
This morning. And was it normal for you?
Yes.
Okay, so I'm quite happy with that. Now moving on to the genitourinary system, it is possible to palpate the bladder. Generally, I won't do that unless I'm concerned. So the easiest way to determine whether I should be concerned is again to ask questions. When was the last time you voided?
Before we came in here.
Before we came in here. And was it normal for you?
Yep.
Do you experience any burning when you void?
No.
Okay. And do you get urgency, like when you need to go, all of a sudden you need to go, or do you know well in advance before you need to wee? Wonderful. So no areas of concern, so I'm going to move on. So far we have covered neurological, cardiac, respiratory, gastrointestinal, genitourinary. The next thing we're going to do is integumentary, which is the skin. So there's a couple of different ways I go about this. It depends on the patient, how alert they are, how aware of what their body they are, and their mobility levels. So looking at Elise here, I know that she's quite mobile. She's walked in, she's well aware of what's going on as well as with what's going on with her body. So I'm gonna ask her, do you have any injuries, wounds, cuts, scrapes, or bruises that I should be aware of?
No.
Nothing. So she says there's nothing, and I've been looking at her skin as I've been going. I see that there's nothing on her face. I have seen a part of her chest when I did the cardiac assessment, as well as the respiratory in the back. I've seen her abdomen. I can see her arms. I cannot see her legs though, so I'm going to take her word for it. She's quite mobile, and I trust that she'll tell me if there's anything of concern. Now, sometimes we get patients that aren't aware of their bodies. It might be because the patient themselves are confused with dementia. It could be that they've got decreased sensations, so they wouldn't feel if they injured themselves. It could be that they're quadriplegic. And also I tend to be more concerned with patients that are more immobile or bedridden, because they tend to develop pressure injuries. If that's the case, then I would do a more thorough integumentary assessment where I'm actually going to be moving the clothes and looking underneath the clothes, particularly at areas that are known pressure injury spots, such as the sacral area, the bottom of the heels, okay? the scapula, elbows, as well as the ears. Okay. So integumentary system, I'm quite happy with that. So I'm going to move on to musculoskeletal. Well, when I was doing the neurological assessment to see if the brain was working towards the hands and feet, I checked her grip strength and her foot strength. Well, that's musculoskeletal, so I can tick that off as I'm quite comfortable with that. I also watched my patient walk in and get onto the bed, and I watched her gait, and I saw that she was walking quite steady and straight, and I'm not at all concerned about musculoskeletal. So the next part is neurovascular. Neurovascular means we're checking the tips of the fingers and the toes to make sure that the vascular system is good. Okay, there's a few parts that we need to focus on for neurovascular. CMS. C is for color and cap refill. M is for movement. S is for sensation. And then the final thing we also need to check is pulses. So I'll start at the fingers here. So I'm going to check her cap refill. Generally we check on top of the nails and we squeeze the nail beds and we're checking if the blood returns within less than 3 seconds. I can also do it on the pads of the fingers and I'll get the same results. So that's quite normal. Now I know her grip strength is normal because she already squeezed my fingers. Now hold your hands out. Does this feel normal to you?
Yeah.
Okay. And now I'm going to check her pulses. I'm checking that they are both equally strong. At this point in time, I'm not counting the pulse because I already did it during the set of vitals. So I feel your pulse, your color is good, your cap refill is good, you've got great movement and normal sensation. Now I'm going to move on to the toes. Looking at Elisa's feet, she's got painted toenails. That's okay,
Sorry.
because we can also check cap refill from underneath. So again, I'm going to check for color and cap refill. Quite good. Her feet are a little bit cool to the touch, but with feet that's generally normal. Her hands are nice and warm, and this isn't cold enough that I would be worried. Now I already see that she's moving her toes, but give them a wiggle for me. Great movement. Does this feel normal for you?
Yeah.
So normal sensation. And now I'm going to check pedal pulses. So for the pedal pulse, I'm going to follow the big toe up until I feel a bump. What that bump is, it's where the bones here join the second toe bones as well. Then I'm going to dip into the triangle between the two of them, and that's where I should feel the pedal pulse. It will be light, it will be faint. Usually not strong enough that you could actually count beats, but I just want to feel that it's there, and I'm going to check both pedal pulses. I'm quite happy with that. While I'm down here, I'm going to look at her limbs. Remember when I talked about the cardiac assessment, where sometimes people could have bilateral swelling in their lower legs? I'm just keeping an eye out for that while I'm down here, making note of it. I have gone from head to toe. I have done a brief neurological assessment, brief cardiac assessment, brief respiratory assessment, brief gastrointestinal assessment, genitourinary assessment, integumentary assessment with the skin, musculoskeletal with the arms and legs, as well as neurovascular with the fingertips and the toes. I have also done a full set of vitals prior to starting all this. I am quite comfortable that I have found no problems, and therefore all I need to do is document my findings in the progress notes. If I found any problems, that is where you need to do a more in-depth focused assessment, which we'll cover later on, and you also need to notify the doctor. I also want to add, don't forget to talk to your patient as you're doing this. Not only is it important to communicate what you're doing, but it's also important to ask them subjective questions. Do you have any pain? Do you feel nauseous? When did your bowels last open? Does this feel normal for you? Those questions help us complete the head to toe assessment. And that is it.